This was a presentation like you, Hyle. Nicholas Brown was meant to be doing it, but he unfortunately could not be with us, so I'm doing it. But luckily, most of them are my slides, not Nicholas's. We do need to understand what works where, when, and for how long. And unless we understand that, we will not be able to use them effectively. And I've got only 3 or 4 take-home messages that will become apparent as we progress during this presentation. The objectives are very simple and were articulated earlier. So when I talked about earlier the 5 or 6 things we need to do in relation to antimicrobial stewardship, what I refer to here is primarily what we do, the action bit, what tools we use, and but we need to have some intelligence about where the problem is. In whatever walk of life you come from, if you don't know where the problem is, you will not know what to do to find the solutions, and then you need to be able to measure how you're progressing with those solutions. So, hands up in your hospital if you have a stewardship program. Hands up. Yeah, okay, I would say about 60%. Do you know where to target the stewardship activity? Do you all know? So some of you are fairly clear where you wish to target. Do you have a policy? Okay, oh, disappointing, only about 20%. Do you have a team, a stewardship team? Okay, only a few. Do you restrict certain antibiotics? Oh, we like restriction, don't we? It's like parents, you like telling people you will not use. Do you do post-prescription review? Much harder. Yeah, I'm seeing very small numbers of hands, so it suggests that not widespread activity. Do you do the hard bit, audit and feedback on a regular basis? One hand up here. All the front row, like the good students, are all putting their hands up, but perhaps not at the back. Okay, so we'll explore some of these. So my first message is you need to find out where the problem is, and you need to tailor the solution. So a solution in Dundee is not necessarily the solution in Riyadh or in Bahrain. So you need to understand what is the problem and what the solution, and will that solution work in your healthcare setting. So that is my first simple message about tailoring what you do. This is a slide that I've borrowed from Philip Howard, and it talks about how you begin to work out where the problem is. Is it where it is complex? So should it be in the ICU, in the hematology, renal setting? Should it be where there is the greatest mortality? In medicine for the elderly, in emergency medicine? Should it be where the problems of antibiotic usage are the highest? Should it be in the most ignorant of specialties in terms of knowledge? Should it be everywhere? And can you do it everywhere? Do the resources allow it to be everywhere? Or should it be only where the people like to adapt new things? And do you want to try to spend all your energies in trying to convince the least amenable people, the laggards? So all of these things should go through your mind when you begin to consider what you need to do. And if you look at knowledge, this is a survey from the United States, and I think it's fairly broadly applicable across the healthcare communities of the world in terms of knowledge and beliefs and attitudes of junior prescribing staff about antibiotic use and resistance. And it consistently shows that within internal medicine, the knowledge is better than surgery, obstetrics and gynecology, and surgery and emergency medicine is about the same. So if you have this kind of information, it might tell you perhaps the educational needs for those professionals are more urgent than another group of professionals if you had to target your educational bits. The toolkit is huge. When the driver or the mechanic is repairing his car, he opens this big box with lots and lots of things in it. But to me, there are actually very few things that work very effectively, and I'll go through them in a brief moment. The antimicrobial management teams are crucial. And to me, this is an overview diagram, and you need to be mix and match and adapt what you have. It does not have to always be an ID doctor or a microbiologist. It needs to be somebody with credible expertise, aligned to a pharmacist and to somebody from the attending teams. I persuade, support a surgeon, an emergency medicine physician, and an internist to be on our antimicrobial management team and group, because they are very important. If you get them to buy in, then you will make your life easier. You need to work with another members of the infection control team. So you need to liaise with the infection control team. You need to have somebody who understands epidemiology, and you need to have somebody who is connected to the support from the hospital administrator. And you need to buy in the medical director, the clinical director, the infection prevention control director to be bought in to the stewardship agenda. And that's an important part of this toolkit. I am absolutely convinced that we need to integrate stewardship and infection control. And certainly in Scotland, that's been one of my big agendas, is how you make the teams. Because, you know, the infection prevention teams have been working for many, many years. They're well connected, they're well respected, and well advised. And we need to work with them. And particularly is we have very good clinical pharmacists, but we're now increasingly exploring the role of nurses in stewardship. They can help you reduce duration. They can help you switch from IV to oral, take the line out, less line infections, get them onto oral therapy. They can tell you the monitoring needs to be done here. They can tell you that patient is ready for hospital discharge. So I think the role of the nurses, working with the doctors and the pharmacists, and I think that in your part of the world, there needs to be a considerable expansion of clinical pharmacists who will support the stewardship program. They are absolutely crucial to stewardship program. And I think we need to work with other teams. We have a big patient safety program in our country. They look at surgical site infections. They look at sepsis. We need to use them and their expertise to help us support the stewardship agenda. To me, they are a very crucial and important part of the toolkit. The evidence I have reviewed already, and I won't go into much detail, but to me, if you're interested and you need to be knowledgeable about convincing people about doing the right thing, I would read these two papers. If you're lazy, just read the executive summaries. You can read the summary and then you can sound very knowledgeable when you're talking to your surgeon, but they are worth reading. I mentioned the first Cochrane review. I think it's limited, already being updated. I think what it shows is one crucial thing, that restriction, we all like to restrict, works when you have an acute outbreak and a problem. But the persuasive educational strategies work long term, and you need to use both. It's like when you deal with your children, all right? You might want to smack them. Now, I'm not saying I smack my children, but you may want to. You can punish them for whatever reason. That's the restrictive bit. But then you need to give them support, education, and an occasional cuddle. I'm not suggesting that you go and cuddle your surgeons, but I'm suggesting that you engage and support them, because that will bring about long-term improvement. And the Cochrane review does show you a bit of that. The strategies are fairly simple around the front end and the back end. And Mark will talk about them in his workshop. But I think that one is less popular. The restriction and pre-authorization is a challenge, and I'll show you the challenge in a minute. I think the post-prescription review is what I favor, but it is very labor-intensive, because you need somebody to tell you that we need to go and review their prescription. Can we get them to oral? Can we stop? Have they reviewed the microbiology? Can we suggest more diagnostic tools? Can we suggest focus control? And so on. So potentially a very rewarding educational tool, but very resource consuming. If you look at the second systematic review, it shows a lot of data for both. Formulary restriction works and does not impact on mortality. So if you stop people or restrict people from using something, the impact on mortality is unchanged. And there is data in this table to support that. If you do audit and feedback, you will bring about a longer-term improvement in appropriate use across the range of randomized controlled trials that, again, are reviewed in this systematic review. But it is more labor-intensive, as I've said. Again, data comes from this review. Remember the oldest paper around audit and feedback and academic detailing. To me, this data comes from more than 25 years ago, that if you spend time face-to-face with your clinicians, giving them data, supporting, education, and getting them to change the prescribing, it has the most impact, particularly in the long term. This is from Philips Global Survey. One of the biggest opportunities we have is on internal medicine and surgical wards. I'm going to challenge Tariq here. I think stewardship in the intensive care unit is important. Please don't get me wrong. But look at the totality of prescribing in a hospital. Does it occur in the intensive care unit? No. It occurs on general medical and general surgical wards. I spend my entire amount of time in clinical practice spending time on general medical and general surgical and medicine for the elderly wards. I think the reward there is much greater because there the variation in practice, and these are ward rounds on medical and surgical wards across the different continents. And you will see, depending on where you have the resource, you do it daily. In ICU, you did it daily. In most of our other wards, we do it twice a week, 3 times a week. It just depends. So I would encourage you to think about that as you practice your post-prescription review and feedback. We like to produce guidelines, and I would recommend this paper. It will all be available to you. It tells you what the strategy is, what the barrier is, but what solutions you can potentially use to overcome that barrier. And I think that is important. So these are guidelines that we like to produce, and this is a slide that Philip has used about using the LEADS guidelines, that how they are made available in every format, and the clinicians and the users have an ability to comment on these guidelines, and you have an ability to monitor the use of these guidelines. We were in India last year in New Delhi, and what they've done is quite remarkable, in which they have brought the guideline to the clinician. So they have a guideline, but what they do is that every year they update the guideline and they put local, relevant, in real-time microbiological data into their guideline. So when you come to prescribe, it tells you the exact percentage last year of the resistance pathogens, what the bug is, what the infection is, what is the likely resistance to those infections, what the current therapy should be, and so on. So it's bringing guideline in real time to that clinician. And I think you can do that, and I think we should be able to do that. We need to make it easy. Remember, it's not everybody's area of expertise. You can't give them too much technological information. So our nurses and junior doctors get algorithms that are easy to follow. This is what I need to make the diagnosis of UTI. This is the culture I need to take, and this is the antibiotic I need to use, and for how long. So we use algorithms of care, and I think they are increasingly effective, particularly in care homes and long-term facilities for urinary tract infection. We're in a technological age, and we're going to hear soon about a technological age in which everybody has an Android or an iPhone. We need 80% of junior doctors use them for everyday clinical practice. Make sure you have your up-to-date guidelines applicable and accessible to them on their smartphone so they can be able to access that information and hopefully prescribe the right antibiotic. This is one that Mark Gilchrist institution used, And remember I talked about the start smart, then focus. Well, it's there. They don't need to go to a journal. When they open a prescribing page, it tells them the principles of prescribing, and then it gives them more accessible information. So that's another important part of the toolkit. When you look at restriction across the world, these are the drugs we restrict: carbapenems, cephalosporins, and fluoroquinolones. But there are many challenges. Just think. Now, when you're sitting there, just think. If you're going to restrict an antibiotic, what do you restrict? Do you restrict 1 dose, 2 doses? What happens at the weekend? What happens on Friday night? How do you ensure its restriction? Is it controlled by pharmacy? Do you use a code? What if the supplies run out? Do you have an electronic solution, which many of you have electronic prescribing? Is it supplied from pharmacy, a central store, an electronic cabinet? What if they've got severe sepsis and you restrict and you get it wrong? What are the consequences of that? You need to think all these practical issues before you restrict. So you need to work those out for the hospital and the systems that you work in. My last 4 slides are around the systems approach, okay? Because we've talked about structural approach, but what an organizational approach and team-based approach, but how can we do better as a healthcare system? Well, we need to design something that people can use. We need to design a chart that will allow them to track their prescribing, and this is one example of that. We don't have electronic prescribing, so in the UK, apart from some parts of England and one part of Scotland, we are backward when it comes to electronic prescribing. So we have to use paper-based systems. So we now have a sticker that each time somebody is prescribed in my hospital, it goes into the notes, and that sticker tells them why they're getting it. Have they looked at the antibiotic review? Have they changed from IV to oral? And it's stuck into the drug cardex. So it forces the person. It's a systems approach. At day 3, you can't write any more antibiotics. You have to address the thing on the yellow sticker before the next prescribing is taken. It's forcing the person to think about antibiotic review. Word of caution. I've talked a lot about all the good things that we do. This is a very recently published study that showed that they put into place pre-authorization for certain antibiotics. And then in the next phase of their study, they kept the pre-authorization, but then they allowed some prospective audit and post-prescription review. So they put in only one strategy to begin with, and then they applied both strategies. And what they showed, interestingly, is that when you release and you allow more education and more freedom in prescribing, the prescribing went up. So whilst we say both are very good, there is potentially unintended consequence that if you stop the restriction, you may actually loosen control. But some people will say that is about antibiotic diversity, and perhaps it's not a bad thing, because it may actually bring about a control of resistance in the long term. Because Tariq's example of squeezing the balloon may become a big problem if you only stick to pre-authorization. So there are challenges in all the strategies that we do. And to me, this is the best study showing that if you stop stewardship, you will lose control. So this is an example of discontinuation of prospective audit and feedback around outpatient prescribing. And as soon as they did that, the consumption began to rise. So it is suggesting that you need to keep going to maintain the long-term solutions. So my key messages is that I think we have a big toolkit. We need to use a range of tools that are adapted and adopted for your local culture and system. I think always keep an eye on the evidence base, understand the limitations and the strength of the evidence base. I think we need to think about how we use guidelines, but to me, I think that they need to work, they need to be durable. But I think what you'll hear in the workshops this afternoon and tomorrow is how do you measure what you do? How do you ensure that you do not do harm as well as you do good? And how do you engage people around measurement? All of these will come out as a theme when you use these toolkits across the hospital systems that you work in. So thank you very much for your attention.